This one? Yes. Okay. Thank you, Hanna, for the kind presentation. This study is part of a Horizon 2020 project called MOCHA, just finished at the end of 2018. The main aim of the project was to compare and appraise existing model of primary care for children among 30 European countries. This project was studied in a wide range of topics. Among them, we analyzed complex care in this study, and in particular long-term ventilation. Children with long-term ventilation are consistently increasing over the last 25 years. They have access to multiple points of care, not only to treat their condition, but also to general, preventive, and curative services. When we speak about long-term ventilation and complex care needs, we have also to take into account the physical and emotional needs of parents and relatives, and that the children with long-term ventilation are generally discharged and treated in their home. These require a continuum of efforts before and after discharge that depends on the level of integration adopted in each European country. The evaluation of this, the degree of care integration, especially in a cross-country comparison, requires the identification and analysis of a mix of interrelated aspects. In this work, we analyze the level of collaboration among primary and secondary care professionals to capture the patterns of care delivery. And to reach this aim, we model the level of collaboration adopting a conceptual framework we have developed during the project that capture and single out the meaningful parts of the child care pathways. And in particular, when we talk about business process modeling, we have two points of view. The first one is the organizational, in which we capture which are the professionals involved in the process and their level of collaboration, their role and the level of collaboration, and the control flow view to capture which are the activities performed during the process, which are the actors that carrying out it, and how the actors exchange the information. How we get the data? We submit a questionnaire to 30 country experts called country agents in the project, one for each country, asking to reply to a set of questions, in this case adapted from the standard for system of care for children and youth with special care needs. And to describe in their country how the different professionals are involved in the provision of care and in the management of care with long-term ventilation. And in particular, in this presentation, I will analyze the development and management of the complex of the personalized care plan, the organization of the transition from the hospital to home care, and the provision of general, preventive, and specialized services, and also how the communication and the exchange of information happen in the country among professionals. In particular, to capture the level of collaboration in place in each country, the professionals are extracted from the questionnaire and classified on the basis of 4 categories. The first one is individual professionals, where each professional work as individual and do not work in a team. The opposite one is fully mixed multidisciplinary team, where primary care and hospital professional work together in a multidisciplinary team. And in the middle, we have hospital multidisciplinary team, where the hospital professionals that work in a team are in charge of the entire care process, and partially mixed when the primary care work in a multidisciplinary team to provide some general services, mainly general services, psychophysical development, or a procedure like this. These 4 categories allow us to define the continuum of integration and to specify which are the countries with a high fragmentation of care, and so individual professionals not working in a team, to a full integration where primary care and secondary care professionals work together. Note that we analyze also if there is a social component in the teams, and in the presence of social workers that support the health pathway. Business process modeling can be analyzed, can be described using different languages and tools. We adopt the UML, which is the Unified Modeling Language, and in particular two diagrams. The first one is the use case diagram, where we highlight which are the macro activities of the process. So in this case, in this example, is the provision of general services, and which are the actors that are involved in this activity, and which are the main relationship between them. In this case, the actors are represented by stickmen, and the relationship are represented by these the different lines that connect the different actors. Moreover, we had green notes to highlight each country, which are the actors that are involved in each country. So for instance, in Belgium, the hospital professional is involved in this, activity, while in UK, there is a multidisciplinary team composed by primary and hospital professionals that work together to provide this activity. The second diagram is an activity diagram in which the actors are represented by swim lanes, and in each swim lane we have the activities that are performed by the relevant actor. The activity diagram is used to highlight the differences and similarities in the activities performed across countries and the timeline of these activities. So in this case, we have the representation of the UK, where we have the multidisciplinary team, which is composed by hospital, multidisciplinary team, and primary care, and all the activities that are performed by each team. Most of them are performed in collaboration. There are dependencies between these two diagrams. Generally, the use case diagram is a high-level picture of the model, and the actors, which are represented by stickmen, and they're represented by the swim lanes, as I said before. And the actors, the provision of curative services, as I reported in the UML, are then represented by micro-events or messages exchanged between the professional, etc. In this slide, these curative services are just split in specialist and general care services, just to give you an example. This is the first result of our work, the use case diagram. We have a lot of macro activities, a lot of use cases, each one representing a specific part of the healthcare process. And each one is associated to a set of actors that are responsible to provide this service for children with long-term ventilation in each country. I think that is very difficult to get in a few seconds, so I select a small part of the diagram. We have the implementation of the written plan, which for us was the monitoring of the healthcare status of the child. And then for each country, we have the actor, or for each actor, we have the countries that are in charge with this activity. The UML diagram allows us to define the 4 clusters of countries and to fill the 4 categories I told about. And we have on the left side of the slide the individual professional, 11 countries out of the 23 countries that have responded to the questionnaire. In 11 countries, there are individual professionals that are in charge with the care of the children with long-term ventilation. The other 12 are distributed among the 3 other multidisciplinary categories. We have also the asterisks that specify if in this country the social professional is involved or not. This is the distribution in the map, and this is just a small histogram to say that most of the countries have a multidisciplinary team, but 50% almost of the country have individual professional, and in this case there are fragmentation. Social care professional usually is not involved, while when there is a multidisciplinary team, generally it is involved. Then second diagram, activity diagrams. We have two countries here. On the left side we have Estonia with a fully mixed multidisciplinary team. On the right side we have Luxembourg with individual professionals. Also in this case I'm going to describe which are the main differences between these two diagrams and between these two countries. They were selected on the basis of the description of the questionnaire. In Estonia and Luxembourg we have more details in the description of the care process. First of all, if we look at the swim lanes, we see that in Estonia there is a multidisciplinary team which is composed by primary care professionals and secondary care professionals, but also we highlight that there is an e-health system on the right side of the swim lane, which say us that there is an e-health system that is used to exchange information among professionals, which is very important, while Luxembourg has individual professionals and not system in place to distribute this information. Child parents, of course, are very important as actors in this process. Second important difference is the burden of the child parent. While in Estonia they are involved only in the development of the written plan with the hospital multidisciplinary team, which is very important, which is very positive. The parents interact with the multidisciplinary team just if there is an emergency or an acute crisis and the child needs to be referred to the intensive care unit. In Luxembourg, the child not only developed the plan, but they are also in charge of its implementation. This means that they have to organize and plan not only the routinely, but also the emergency child visits, and that to take the information collected from specialists in primary care and take to the other professional to communicate the status of the child, while in Estonia, as I said before, we have a shared record which is national and where all the information of the child is collected. So in conclusions, main results of this study is that primary care professionals are involved in the majority of the countries, and while hospital professionals are still a reference point, even when the child is discharged at home, the presence of social work in a multidisciplinary team indicates that in the majority of the countries with the integration of care, the social component is included to identify and fulfill child and family needs. The adoption of a personalized plan, and in particular the involvement of the family in its development, is an optimal feature in the treatment of child with complex care need. And the communication process, of course, is facilitated by the use of shared records, and this is very important considering that in the community, in the care, home care, the primary care and secondary care professionals are involved and they have to work together. Considering the results of our methodology, the adoption of business process analysis allowed us to identify the different patterns of collaboration adopted in the European countries in the continuum of integration. The use of UML made it possible to represent the different strategies adopted in the country, also to analyze the organizational flow, the organization and the control flow perspectives, and this provided an additional view, and this contributed to the analysis and to the results obtained by the MOCHA project, gaining insight to the different efforts necessary to implement optimal model of childcare. which are the ongoing work. We describe the process, so we can associate to the different diagrams business process metrics to measure the performance of the process in terms of time or in cost of the process, and also to capture which are the bottlenecks and the solution that can be implemented to improve the process. To do this, we select a set of UML elements, activities, interaction among actors, decision points, or waiting times to have a first snapshot of the efficiency. Of course, this is only efficiency. What we have to do is also analyze which is the effectiveness of a process, and this can be done by associating to the results of the efficiency, to the results of the business process, outcome measures such as the expenditure of health professional, avoidable hospitalization, as we have seen in the previous talk. Of course, what we need to perform this analysis is to rely on available and robust data to be analyzed. Thank you.